The Community Hour on 99.8 Hours FM.
Warm welcome to you guys to the Community Hour here on Awaz Radio. You are tuned into 99.8 FM here in Southampton and on the DAB channel 70 in South Hampshire. Now, over the last few weeks, we have been talking about the COVID-19 vaccine, the myths surrounding it and the rollout of the vaccine. But more importantly, we started to talk about the need for the BME community to start taking up the vaccine. And in today's program, we will be concentrating a lot more on the vaccines, its importance and the research that goes on behind it. Now, just to recap what we have covered so far, in the first community hour, we covered the importance of staying at home, the COVID-19, what is COVID-19, how it affects the body, how is the South coping, what we should be doing to help the NHS and ourselves, why are people from ethnic minorities more effective, and we sort of talked a little bit about an introduction to the vaccine and its rollout. In the second community hour, we talked about why there is a need for a vaccine, how it's developed, how it works, the role of the GP and the health workers, if the BME community is more affected and the areas that they are affected in, is it safe? And we had a whole load of questions coming in from you, the community. You can find the recordings on our YouTube channel as well as our social sites. And indeed, if you would like to contact the studio, we can direct you accordingly. In the studio today, via Zoom, as always, I have my guest, Sol Post, who is the lead researcher for vaccines at Southampton General Hospital, Professor Anoop Johan, who is a consultant from Portsmouth, and Dr. Ayman Al-Zatani, who is a consultant from Southampton. We also have members of the public who have kindly joined us on Zoom, and they will be joining the conversation a little later in the show. So let's start with some of the questions that you, the audience, have been sending in to us over the last week following the previous programs. And so if I could start with yourself, a very good afternoon to you first, all of you, all my guests. Vaccine passports, are they necessary?
Well, vaccine passports are really interesting. And I think the problem, as the Minister for Vaccines outlined, is that if we don't want to do in the UK is create a system of division where some people can get a passport and do things and other people who maybe haven't had access to the vaccine yet are left out for a period of time. So I don't think anything's going to happen quickly, because I think it's very likely the government are going to want to offer everybody the opportunity to have a vaccine before we start talking about needing a passport for use inside the UK. We might need it for travel abroad, but again, I think until everybody's been offered vaccine in the middle of the summer, it's very unlikely that even if we were allowed to travel, the other countries would let us in. So at the moment, I think, you know, we're trying to get people to have a vaccine because it's the right thing to do, and not put any coercion on the public and not force them to have a vaccine because they feel they have to. But it might be that vaccine passports come in for travel, and then it might be that individual companies or sectors decide to make them compulsory for different activities. But I don't think that's going to be government driven. I think, and from the health service point of view, as we discussed last time, we don't think vaccines should be compulsory, but we really would like people to choose to have them. And I can see, Ayman, you trying to come in too.
Yes, sorry, I think there is an issue here. I think we definitely, like Sol was saying, that we need to first do it for the patients, for the people's welfare and health to start with. And the government obviously that will be the main drive. But the problem will be is that some sectors of work like healthcare, social care, front-facing businesses may choose to have that as a condition for employment, and this will then create a problem with some people. Like as a surgeon, I can't practice surgery without having a hepatitis B certificate saying that I have enough hepatitis B antibodies to stop me from infecting my patients. So it's the same with some, so there may be not a government-driven, but business-driven health sector to start with, although there was some talk about some other services which are front-facing, public-facing, like plumbing, and there was a company manager who is a plumbing company manager saying he will insist on his employees who are going into other people's homes of having a vaccine as a condition of employment. I think this is where the problem is. And my worry is for our BAME communities, they might find themselves disadvantaged because we know that the pickup within them of vaccine, for which is a battle at the moment. Hopefully, we are winning that battle. Might then, with the younger age group, might feel again that they are not interested in this, but they might find themselves pushed out of jobs, which could be because of this. So I think that's my worry long term.
So isn't it the scientific field, the science field, who's actually advising the government that we need to have passports?
No, I don't think so. I think everybody in the UK was just trying to think, well, we should certainly the infectious disease doctors and the vaccine doctors have not proposed passports. I think some people outside the UK have been talking about them and the travel sector, but at the moment, the priority is not to think about passports. That's for later in the summer.
Professor Chauhan, many countries around the world have rejected vaccinating the whole population. So 100% vaccination is out of the question. What's your take on that? I mean, the Prime Minister has been proposing that everybody will get the vaccine.
I think achieving 100% vaccination status is always going to be difficult in any community, simply because a lot of people may be excluded because of medical conditions and allergies, but others will have the ability to make a personal choice. So I think the closer you can get to it, the better. And we know the reasons why it's important, because it reduces the infection. And if you have less infection, you have less symptoms. If you have less symptoms, you're less likely to spread it to other areas as well. So it provides some assurance, I think, to all the members of the community to try and have as many people vaccinated as possible. So it goes back to the very first point we just discussed earlier. What assurance can a community have that a group or group of individuals are low risk in terms of transmitting infection? And there are many ways, but I think having something like a vaccine passport drives behavior. And there's no doubt, I think, that legislation of any form done appropriately in the right situation can drive behavior. We've seen the risk of road traffic accidents and seatbelts. What effect has that had? And also banning smoking in public places because it's a public health hazard. Coronavirus infection is a public health hazard. So we need to take steps in order to reduce that infection across there as well. So going back to your question, is some countries have chosen not to. I'm not aware of the reasons why countries are choosing not to, but I think it's an aspiration of all countries to do that. However, I don't think it's a choice. I think it's a situation that we need to be responsible for our global community rather than countries. And there is an argument that countries that are resource poor will have less access to the vaccine as well. So it's not as if it's a conscious choice that they're having it. It's just that they will be lagging behind as well. And I would make the view that actually we need to take a much more global view around this pandemic. I would like to see every healthcare worker in the world, for example, vaccinated before we start vaccinating young, healthy people in one particular part of Europe or another country. So I think with a much more wider sense of community in the global pandemic, I think it's really important that every country is given access to vaccine and not dependent on the allocation of resources.
So
and
what,
that's
so
what
what happens?
Sorry, I was just saying, so what we don't want out of all of this is to drive division. If you have countries reaching 80, 90% vaccination rates, others are well below 50%, that's inequality, and that just drives the world apart. So I think it's really, really important that we address the reasons why, and vaccine shortages, availability. So I think it's a responsibility for all of us to make sure that vaccine is available in every country. I don't think anybody's consciously making a choice not to vaccinate everyone.
What happens if, say, for example, we travel to a country where they haven't got 100% vaccine or a lot of the population vaccinated, and then we're coming back from that?
It goes back to the very point. I think in order for that individual, sometimes they make a choice to travel, or sometimes I go for business and try and get that global community to go back to normal. It will always be a risk. If we go to a high risk area, it's even more important that you have the vaccination as well. And all the more important that those vaccinations are proven to be effective. And we'll talk about the reasons I believe why that's important. My research plays into that. So yeah, it's a risk.
So very, very quickly, you wanted to come in.
I was just going to use that into leading into research. I mean, I think Anoop's absolutely right. And some of the studies we're doing at the moment to look at the schedule and whether 1 month or 3 months is the best thing to do, and whether you can give one vaccine after the other. Some of those schedules, we're doing the studies too late for Britain. We're doing them because we're going to inform how the rest of the world can use vaccines. Because as we've seen this week, supplied to different countries might not be the same vaccine in the same week. So it's really important that we in the UK also are able to help with that research and let the other countries know how to deploy the vaccines when they get them. But Anoop's absolutely right. It's critical we avoid inequalities. And if people want to go abroad, the safest way to do that is to have had a vaccine, because that's a better way of protecting us, bringing it back into the UK. And the vaccines reduce transmission as well as preventing ourselves getting sick.
Sort of that brings us nicely on to the vaccines itself, which is the topic that we want to sort of discuss quite in detail today, research and its importance. And so you're the leading researcher at Southampton. Tell us a bit about your work and why research is so important.
Sorry, research is involving the whole community. And although I'm leading the Wessex, the regional regional research network, actually Anoop runs the research department and for the Portsmouth Hospital, and Eamon's involved in research in Southampton. And research is something that most doctors, we hope, will take part in, although some of us do more of it as part of our job. So actually it's important to all of us and the whole health service. And we've seen in the pandemic the importance of people taking part in research to get new treatments and medicines. And Britain's led the world, right? So we've got the recovery trial that has given the world the only treatments that we know that have proven to be useful in COVID, with the steroids and the new one, tocilizumab. But we've also been able in that trial to show people that other medicines that don't work, that people said might work, and stop them doing harm. And then we've got the research about the genetic mutation of the virus. And all of that's been done in the UK. You know, we've sequenced 50% of all the types of virus that have been sequenced in the whole world. And that's because of the expertise. And Portsmouth have been leading that on the South Coast for all of our hospitals. And then we've got the vaccines. And this has been a big national program where the UK has taken the lead and been working with all the different companies, but also with the public sector to work out what trials we need to do to provide vaccine for the UK, which we've done, but also now for the future, for the world, and how we're going to use the vaccines in the real world. So, and it's been absolutely brilliant how many people across the country have taken part. We've had nearly 500,000 people sign up to volunteer to take part. And in the South Coast here, we've had nearly over 2,000 people now take part in actual studies. And so it's been a brilliant effort by everybody.
Dr. Sultani, one of the things that we haven't had a lot of is the BAME community, the Black Asian ethnic minority. People have not come forward for the research. Why would that be, do you think?
Thank you. I think there is a variety of factors which to do with there is a long-term sort of or deep-rooted sort of health inequalities which have basically prevented the BAME community from engaging properly with the healthcare system. So this is the background we're coming from. Now, it could be socio-economical, educational thing, which been going for some time. We know that's been tackling it over many years. And then, so this is the wider background we're looking at. And then, which means that to engage in research, you need to be engaging with healthcare system as well. And we know all this, you know, if you look at the non-BAME population, there's an understanding there that taking part in research means that you get cutting edge kind of treatments and you may have better outcomes. And there's a lot of literature there saying that. So I think it's not that the BAME community does not want to engage in research as much as the access to healthcare has been unequal over many years. And that has prevented that community from benefiting from this kind of research. Now, I think we have a golden opportunity now with the spotlight on the BAME higher incidence of COVID infections, that we can capitalize on this kind of opportunity to encourage them to take part and say, and there are a few studies out there, and there are some studies which we're running in the hospital for healthcare workers who are from BAME communities and their risk profile, and whether that has a bearing on COVID infections, which again, with the first wave, we've found that a lot of that community, which is healthcare worker, has been more affected by it. So I think we may be able to reverse that kind of lack of engagement in research by using the publicity created by COVID and the COVID incidents to get more inroads into the community. And hopefully the government is working hard on increasing tackling health inequality in general. So hopefully that will work in our favor.
Professor Johan, in Hampshire as a whole, have we been seeing a lot or have we been seeing any people from BAME communities come up, and where is the uptake higher and where is it lower?
It's a very good question. Yes, we have seen people from the BME communities come forward, but not enough. Not enough to the levels that I think we need to. The three things I think we've got right during this pandemic, especially in the UK, is research. I think it's one of the highlights, as Sol has said, but also genes and you know, vaccines as well. I think those have been the three leading lights, and we've been leading the world on that. You know, over half of the sequencing of the world of the viruses occurred in the UK as a result of what we have done through these research laboratories. And that's what's told us about the different variations, the things that we call chains of transmission, how they spread through the community and hospitals and care homes. So understanding that, and you know, we were the first to report the Kent variant and then the South African and Brazilian, and recognizing all of this requires access to that research. So whilst we have all of that world-class research, why are we not getting enough BME members of our BME community coming up for research? And there's no easy answer. There are lots of things that we want to try and address. There are language barriers. There are often education or misinformation from individuals. So I think everybody from the BME community has a responsibility to make sure that everybody in that community has the ability not only to get to the vaccine, but also contribute to the research. And it's really important because the BME community have by far the greatest risk of dying from this vaccine. And we have some of the world's best research on our doorstep. So why do we not engage? So it's really important that we try and do everything. So the things that we're trying to do in Hampshire is to firstly, try and make sure that everybody's got access to vaccines that have been tried. So we've got GP centres, hospitals doing the vaccination hubs as well. But we've also got 2 research vaccine hubs, with one soon to be open in Portsmouth as well, to try and cover the whole of the Hampshire area. By doing that, we want to make sure that everybody, not just the BME community, but also those that are underserved in our inner city areas where there's also poverty, and poverty and BME community often go together. So it's important that we try and address those inequalities as well. And also the research trials, they do not exclude people from the BME community. In fact, what they do is actually encourage them as well. So there's absolutely no reason for anybody from the BME community to think that they're not suitable for any research as well. The research that we're currently doing is suitable for everyone.
If I can put the question out to all three of you, seeing as you all do some sort of research in one way or another, it's not very well promoted in the ethnic minorities, whether it's in ethnic minority media or in ethnic minority organizations or institutions. How do you address that?
Well, that's why we're here, Ali, and for you to tell us. I think the whole of the research community in the UK has realized again during the pandemic that we haven't done enough to reach out.
I mean, why has it taken you this long? I mean,
that's
research has been going forever.
Listen, let's just put our hands up and say we didn't know what we were missing and it wasn't clear. And I think we've got to address that both now.
I beg to differ on that. So because you know that you don't exclude everybody, so you do know what you were missing.
Not really, because we've never counted before whether people are white or black or Asian when they come to take part in trials. But
okay.
when we've seen what's happened in COVID, we're now counting, and we're now looking at our staff, and we're trying to make sure that there are loads of people from the BME community who are.
Didn't you count this when we had cancer, for example?
Yeah, but we've got listen. The whole country's got a problem, right? We across all our healthcare staff, we've got black, Asian, people from all diversity, but we also realize that not enough people are coming into research to work in research, and we need to find ways of engaging with the community. So listen, we're here to have this conversation with you. We'd love to know what the community would like us to do, and we don't want to be patronizing and tell you how to do it. We need to work out who to engage with from your communities so that people can say, look, we'd like you to come and do this. We need the information in this format or that format. So we're here to learn as much as to explain.
Brilliant. Sort of while I got you on, or while you're unmuted, so explain the difference between a recombinant vaccine and an mRNA. Okay,
so it's not really recombinant vaccines. The two vaccines we've got at the moment, one's an mRNA vaccine, okay? And if you like, that's like a Snapchat message to the body. Our body's genes normally take our genes and we make RNA in our body in order to make a message to tell the body what to produce, which proteins, what the cells do, how they work. And so the RNA, if you like, are the temporary messages in the body that tell the body how to work. And so by giving the mRNA for the spike protein, that's just one of the 25 proteins in a coronavirus, we can stimulate the body to produce an immune reaction against that coronavirus. So if you like, it's providing the temporary message to the body that then gets it to stimulate an immune response against COVID and remember that COVID from before. So it's not making a COVID virus, it's just making one of the 25 proteins. So it can't get into your DNA, it can't affect your genes. It's just there for a few minutes and then it disappears after it's given its message. So that's the RNA vaccine, that's the Pfizer one. The Oxford AstraZeneca vaccine is what we call a replication incompetent viral vector vaccine. So I'm going to
that's a big word,
right? All that means is it's a cold virus. It's a chimpanzee cold virus that's been deactivated. So it can't get into it can't give you a cold. It can't give you a runny nose. But what it does is when we inject it into a muscle, it's the virus that produces the spike protein, the cold virus that produces the spike protein that then your body provides the immune reaction to, instead of being the message itself. So it's just a different way of delivering the spike protein to the body's immune system. And it also produces a really good immune response with a memory that the body can then remember in the future. So we know quite a lot more about this type of vaccine actually than the mRNA ones because they've been studied for many years. And there's other vaccines for Ebola and other diseases that use the same technology.
So in layman's terms, it's one goes on the motorway and one goes on the A road?
No, they're both motorway vaccines. I mean, it's incredible. They both work. They're both 100% effective at stopping you going into hospital and dying. The differences that you read about in the percentages are not, you can't compare one with the other because the way people are counting coronavirus is different. So for the Oxford studies, we counted it even if you got a cold or if you just didn't get the full, but as for the Pfizer vaccine, they counted coronavirus by having the full set of symptoms. So you can't compare that percentage. The really good news is that all of the vaccines we have, including the new one that's going to come in a few weeks' time, the Novavax one, 100% effective at preventing going into hospital and death in the trials. And we saw this week from Scotland and from England, really good real world data. You know, the data from Scotland, over 1 million people who've received the vaccine. Some of them have gone into hospital, but you know, these are very old people who received the vaccine first time round. It's really amazing how the vaccines are working in the real world.
Dr. El-Sultani, we've now had a whole load of people who need to have the vaccine, you know, in care homes and whatnot. They've had their first vaccine. So we've sort of seen, before we had clinical trials, and now we've sort of seen people who've actually had the vaccine. What sort of feedback are we getting? What sort of death rates are we getting back? You know, is it coming down because of that, or?
So the situation in the hospital is that the red alert or the has gone down. The rate has definitely gone down in our area. What we have now is the patients who've already been ventilated in ITU. I'm glad to say a reasonable number of them are now making progress towards coming off the breathing machines. So at some point we got up to 70. And now we're nearly sort of 30. So we have the number of those on breathing machines. So we are seeing a tangible evidence of less numbers coming through. Now, what was worrying as well is that the age of the people we were seeing was younger. I think because the first vaccine went to the very elderly. So I think in an interesting way, those have been protected because most of what you see in the hospital are from the smaller age group, which have not been in the first wave vaccination. So I think, obviously we need to wait for the final results from all the sort of information coming back from different parts of the UK. But that first wave of very elderly, care home people, vulnerable, being vaccinated has protected that group from coming through the system. So we have hardly seen, you know, when I was doing my shifts in ITU with proning patients, I hardly seen any old people there, which is good. You saw the middle age, you saw people in their 40s and 50s. I think there was one maybe 70-year-old, but then that's a reflection, I think, how efficient the vaccine program and the rollout, getting 50 million people vaccinated in a record time, meant that that population now has been more or less protected. And now we're looking at the younger ones, you know, the 70 going down to 50, which hopefully between now and May or early June, hopefully we'll get those vaccinated. And I think it's a long game. It's a long game. We need to basically reduce the amount of population vulnerable, which the virus can hide in, and sit there lurking around so that it just jump and create another spike. So the more we can squeeze it into smaller pockets, or hopefully no pockets, the better it is. And I think when going back to, just to comment on Anubi's point about the whole world, by making the vaccine available to as many countries and population around the world, we are reducing the opportunities for the virus to sit in certain pockets around the world and cause mutations and resurgence, which can come back to us. The thing is that nobody's safe until everybody's safe. I think that's never true than this time, because again, in the future, if this virus is going to come back, it's going to come back from the pockets of people who have not been vaccinated, not from us. And it comes back into a different mutation. So I think the news we have, what Saul has said about the first trials which have reported back from England, from Scotland, is very encouraging. The view on the ground in what we're seeing on the front line looks very good. And I think the long game is we need to push for the vaccine to be as widely available within this country and overseas and abroad.
But before we were saying that children don't need to be vaccinated, and now we're sort of looking at children to be vaccinated as well.
Yeah, well, we're starting the children's trials because children don't need vaccination to protect themselves, all right? Because children aren't getting serious COVID as a general rule. But we regularly, every year, we use flu vaccine in children to protect the old people in the population and to stop the vaccine transmitting flu. And that's why we're testing the vaccines in children, because if by the end of the year we've got a safe dose to use in children, we know how to use the vaccines in children. And if the vaccines reduce the virus transmitting in the population, then actually it will benefit the elderly, the people at risk of COVID. Even if they've received vaccine themselves, will be able to use the vaccines in children and secondary schools and maybe even primary schools, just to reduce the transmission even further and reduce the chances of mutations occurring in kids that then could have impact on the adults who, if the vaccines were to not work because of that mutation.
So are you saying children are carriers?
So children, secondary school children can catch COVID just like adults, but they don't amplify it anymore. People are, the debate you are hearing in the newspapers is because for influenza, children expand flu. It's like they're amplifying it. Whereas COVID, that's not true. We know now that if you're secondary school age and you're a child, you've got just the same chance of catching COVID as an adult. And that's the way it works. But if you're a primary school child, it's about 50% the chance of catching COVID, and you don't get it for very long and you don't transmit it as easily. We don't really understand that, Ali, but we are going to be working out whether, not even if, whether we should be using the vaccines in children during this year. And that decision will be taken right at the end of the year when we know more about the disease and about the vaccines.
You mentioned about mutation, but if the virus is expected to mutate, does that mean that we need to develop more and more vaccines each time?
We are, and we're doing a study, we're leading a study in Southampton that's going to start in June or July, where we're going to be testing a booster dose of the mutation vaccines. These are the same vaccines we've got, but they've been tweaked against the known variants. So we'll be doing that research so that the country can decide what to do in the autumn, and we'll have that evidence in good time. And we're going to need people to take part in those trials, and there'll be people invited who've had the vaccine already when the time comes.
Professor Jahan, if I can move to you, because what sort of research are we doing at the moment, and in particular, in relation to the BME community?
There is research happening nationally to help us understand why members of the BME communities are at greater risk. And these include quite intensive studies in people who had the infection, and they include follow-up questionnaires and doing in-depth interviews in individuals. So I think there is research specifically targeting BME communities why our risk is higher. So we need to understand that. But there is obviously other general research that is occurring at the same time, in which the BME communities can then access from that same point. So I would reassure all our community members, yes, there are specific studies that are now being developed by the National Institute of Health Research that is looking at why there is that what I would call the medical and the social inequality that gives rise to the reasons for the increased risk of infection, which are not just medical, but they're also societal problems as well, which need to be researched as well in the same way.
What sort of research is happening in our area?
Well, there's lots of research. So we've talked a lot about the vaccines research that's happening across Wessex, and we will have 3 vaccine hubs by the end of next month. So that's important. It's important to do different vaccination studies simply because of the reasons we talked about already. There'll be variations. We also need to look at those groups that have thus far not been studied, in particular, those who present the highest risk group. So the obvious one is we need studies in BME community. We need to understand whether pregnancy, what the safety is. We also need to understand what's the route of administration. So at the moment, everything is injection. Can we instill the vaccines through another route, such as an intranasal route, for example? And why is it? Is the risk any different in somebody who's older or might have other conditions that reduces their immunity, such as diabetes? So all those areas, understanding risk, is where our research is going to be designed. So that's vaccine studies. However, if you become unwell and visit the general practice, and if you don't have serious infection, thankfully enough to require admission to hospital, there are studies that are occurring in primary care in Wessex. The principal study, for example, that is looking at different treatments for patients with milder forms of COVID disease, but also for those people who then become really unwell and require admission to hospital, from an admission to requiring oxygen and increased treatments to even being on a ventilator if they're that severe enough. There are studies along all of that helps us decide risk and different treatments. And the treatments that we have tried in Hampshire as part of the larger trials are looking at different drugs, different antibiotics, different anti-spike antibodies that have been using. We've also been using plasma therapy as part of all the studies. So a whole plethora of treatments are currently being conducted throughout Wessex, as they are across the whole of the UK, in order to test different treatments. So there's plenty going on.
Dr. Al-Zitani, some people are saying that, these researchers are doing their research without you knowing. So can you explain the difference between a case study and a research?
So I think research is when you have set up a protocol where you have a question you need to answer, and you are allocating either observation, sort of a treatment or an investigation, and you're approaching the patient and explaining what you're doing, and the data is gathered to answer a particular question. Case study is looking at things which already has happened. So in a way, most of the research usually is looking at something to be started in what we call prospective. Although there are some retrospective studies where we look at certain groups of patients, but case studies is when you are looking at, let's say, all the patients who've had COVID, all the patients who've had flu, all the patients who had a particular illness, and you look at them, try to analyze why the outcome of one group was worse than the other. So you are not already sort of dealing with something which has happened, and the good studies are the ones where you can get as much information, you can group the patients, and you can get some meaningful conclusions.
So am I correct that a case study can be done without consent, but a research has to be with consent?
No, you still have to have ethics, because any kind of information related to a patient is still his data. You can't use it without having permission. Now that sometimes some of the patients, when they go into a treatment center and they sign a form or something, some of those forms will involve a clause which says your data can be used for ethically approved research. And in that case, you are basically delegating the decision to allow your information to be used by the research team. If a group of bodies, which involve some public members of the public, and some people who are sitting on ethics committee, who say what you're doing is good medicine, is good research, and we think that getting these information for that study is okay. So there's always an element of consent, which could be upfront, or it could be implied, or it could be done with a knowledge of, but having to be ethically approved. Nothing is going to be done sneaked under the carpet or without people's knowing. I don't know whether, Saul, do you have anything to add?
I was gonna come on to Saul. So you're right at the forefront of this. A lot of the research is funded by the big pharmaceutical companies, and some of the vaccine manufacturers have a legal liability protection clauses. So what is the deterrent for big pharmaceutical companies not to push for repeated vaccinations for this type of virus or any type of virus that mutates so rapidly?
Yeah, so I mean, it's really important that we work as doctors with the drug companies, whether they're making vaccines or any other medicine. I think in the past, there have been some very well publicized bad practice, but certainly in Britain and Europe and America, that's gone away now. And we work very closely to only do studies that are ethically appropriate, as Eamon's just been saying, and where we don't know the answer. So we always try to do studies that are genuine research questions that the NHS needs to know the answer for. And we don't make money from these trials in the UK. So for the vaccines, for COVID was really interesting. The government went out and they created the Vaccine Task Force, and that had people, experts on vaccines as well as business. And we sought out the companies, the UK sought out the companies that it wanted to do the trials with in order to ensure the vaccine supply. And if you look at Oxford University, they designed the AstraZeneca trial, this vaccine. They looked around the companies and they said, we're only going to work and partner with a company who are prepared to do this for free. So Oxford University insisted that AstraZeneca make not 1 penny of profit during the pandemic. And we've already seen the technologies being given by AstraZeneca to India, who now make more vaccine than we make in the UK, because they've got enormous factories producing vaccine for the Indian subcontinent. And yesterday was really exciting because COVAX, the WHO, the World Health Organization, umbrella organization that's collecting all the money for distributing vaccine amongst the world, they delivered their first batches of vaccine from that Indian center to the other countries around the world, which was really exciting because that's as Anoop was saying earlier, we've got to avoid that vaccine nationalism. We've got to make sure.
Do you have like I mean, how do you choose the companies? Do you like have trusted companies, and some of them you look at them and say, I'm not too sure about that one?
No, drug companies have to adhere to very strict laws and rules and legislation and ethical standards, and all of this is monitored by the MHRA on our behalf, the Medicines and Healthcare Regulatory Authority, the FDA in America, the EMA in Europe, but also by the ethics committees. No research can be done in the UK or anywhere in the world without an independent ethics committee, which has got lay people and non-specialist experts on it. That ethics committee has to agree exactly the research that's going to be done, the protocol, the documents that we show participants and patients, everything has to be approved. Even the adverts, even the text that we can read out to you on the radio about a study has to be approved by the ethics committee. And the public can be fully confident that an independent group of people has looked at every single bit of research before we're even allowed to approach you to do it.
Okay, I want to bring in our guest now. So if I could start off with Atif, you have a question for our panel. If you want to, yeah, go ahead.
Yes. So one thing with the safety and the history.
You want to come closer to the mic?
Yes. So in our recent history as a global society, I'm just going to bring into the extreme examples of safety. Grenfell Tower's cladding was safe a couple of years ago. The Boeing 747 MAX was safe a couple of years ago. Both of these turned out not to be safe. What is my insurance as the person taking the vaccine that this was handled in a much better way?
Yeah, that's a really good question. Listen, we've been using vaccines for over 100 years now. And my parents knew people at school who died. My grandparents had lots of their peers at school and children their age who died when they were small. And we've created better healthcare across the world by having vaccines that have got safer and safer. So the technologies that have been used to make COVID vaccines, apart from the mRNA ones, which are new, have been studied a lot, and that's how they've been able to be manufactured. And none of this research has been done, cutting any corners. The studies that have been done have had tens of thousands of people in. That's way more than normal. It's been done quickly because all the other research has stopped across the world so that we can do the COVID vaccine research and the treatment trials. That's given a problem in respiratory care, in cancer, in diabetes. because we haven't been able to do any of that research for the last year. But people can be sure that the vaccine research we've done has shown that the vaccines are safe. It's based on technologies that we've understood for many, many years. And we've now given millions of doses across the world. So we know that they're safe. We really do. It's not biologically plausible for long-term things to happen as a result of a vaccine. As an example, we go out, we have a restaurant, a meal in a restaurant. Maybe we've not been to that culture before. I might go to a Japanese restaurant for the first time. I'm going to taste some flavors in my mouth that I've never experienced before. That's the same as receiving a new vaccine. There's hundreds of things we breathe in every day that do the same, that our immune system handles and adapts to. And vaccines are no different, but we've tested them and we know that they're safe.
Professor Dan, yeah, can I just add to Sol's point as well? So research is not just about the front end. It's not just about developing the vaccine and then looking at infections in the short term. The type of research and the reassurance that we have is that research is ongoing. So there are studies that what we call post-marketing studies. So once a drug has been given, there are long-term outcomes as well. So we're always monitoring the safety of this as well. And also once something has been licensed and in use, our safety net doesn't stop there as well. So we have systems in the UK where we will monitor for unusual side effects, and doctors prescribing certain drugs and things will be looking out for side effects, and that then goes up to a national system. So the intelligence of the data is continuously collected as well. Unlike some of the other examples that you have, which is a one-off thing, and then there's no long-term monitoring with research. The research begins at the front end, but the monitoring continues in many instances for many, many years.
I think you have a follow-up question.
Yes, my follow-up question is actually about the mRNA technology, of which I didn't find any long-term clinical.
You need to come closer, Ati.
The specific question is, I listened to an interview from a Pfizer scientist who worked on mRNA, and he specifically said that when this little message goes into your cell, the spike protein will be expressed on the surface of the cell. My question is, did my immune system ever see anything like this in its whole history, that my healthy cells start growing spike proteins on the surface?
Yeah, so all of our cells, the body's turning over rapidly. The spike protein itself doesn't last very long. It goes and then it's addressed by the immune system. And you're right, the RNA technologies are quite new. They've been tested for quite a long time in cancer biology as anti-cancer vaccines. That's how these guys were ready to go, the BioNTech and Moderna, because they've been looking at ways of fighting cancers using this type of vaccine for the last 5 to 10 years. And they've only really been able to be effective this time because people worked out how to do that without causing a huge local reaction. In the past, getting the mRNA into the body's been quite hard, but they worked out how to do that using the fatty coating that lets it go in. There are lots of things that our body produces that they don't. Different cells produce different chemicals and different proteins. And you're right, this is something new, but it's very localized to the cells which actually receive the mRNA. After it's gone, it's gone. You can't suddenly, your cells can't then suddenly carry on making that spike protein, and the body's immune system will get rid of those cells. So there's not going to be anything left. If you went in a few weeks after looking for the spike protein on the surface of cells, we wouldn't see it, even if that's how it worked, because the body's immune system will have got rid of it. And there's no more message, and your body can't remember that message. So,
yeah, sorry, Felix.
Based on what you say, Guy, and everything, for example, the Professor Anoop, he said about the vaccine is going to be a personal choice, but the personal choice going to be like I don't want the vaccine. I can travel to see my parents in another country, or maybe I'm gonna, if I have the corona, I'm gonna have a health care or health service. Because
yeah,
what about the people who don't want it?
So we're not politicians, all right? As scientists and doctors, what we're going to say to you is, look, we can sit here, we'll sit and answer your questions until you're happy to have the vaccine. But what we'd like to do is for you to be confident that you and your family can go and take the vaccine and protect yourself and help reduce the transmission. Any decision on stopping people traveling is not going to be taken by the doctors and the vaccine scientists. That's going to be taken by the government and politicians, both in this country and abroad. And we don't influence that. Nobody phones us up and asks us our opinion. These are things that the government have to decide on our behalf. And whether we voted for them or not, we're stuck with them for another 4 years.
Felix, follow-up question.
Sorry, at the end, it's not personal choice. It's not.
No. Well,
no. Listen, if you don't want the vaccine, I can't pin you down. I can't force you to have it. But I also, that's why I was saying at the beginning, I think vaccine passports are really complicated because they're almost like having a vaccine passport is like forcing people to have a vaccine or you can't take part in society. We've always rather made vaccines voluntary in this country because that's generally a better way of doing it. But we need the opportunity to convince people who aren't sure to be able to have the vaccine confidently. That's why we're here. That's why we would like to know how better to engage. And I can see Anoop and Eamon are dying to come and explain it better.
Dr. Ozatani.
Okay. I think, Felix, you're mixing up between what's happening in the UK and what will happen when you want to travel abroad. And we know that over a year now, some countries have already been implementing some sort of quarantine and some sort of restrictions on travel. We in the UK were one of actually the late adopters of that. If you look at some countries, they've already many months have said you can't travel or you have to quarantine or you have to have a test before you come in, or when you are on your arrival, you have to have a test. So that is something which the governments around the world have to agree between themselves, whether you get vaccinated or you get tested or you get quarantined. A combination of these will influence how your movement around the world. Now, the question is around the work in the UK. And I think it will be a brave politician who will make a law saying that you have to have it. I don't think it will happen. I think it will still become a choice. But the facts on the ground is whether the companies and the job markets and the free economy may dictate that some people will not find a job in a sector unless they're vaccinated. But I don't think I can imagine in this country, whether from an ethical point of view or a political point of view, it will be something a government can force us to have. But we are appealing to the good nature of people, saying that there's a lot of good science there to say there's a good case for us. We've all had it. The 3 people here who are you talking to all had it. And we will be happy to have it, to give it to our family members. I've given it to my 84-year-old parents because I think that's the best protection they can have. So this is what we're trying to now put the case to, but we will never ever consider forcing anybody to have a treatment. We know that we do that every day in our work. We have people who refuse cancer treatment, people who refuse heart-saving surgery, life-saving surgery. So these are far more complicated treatments, which we know have been working forever, to save people, but people do not want it. We can't force them, and I think the vaccine is no different.
Dr. Chauhan, Professor Chauhan.
It's a really good point. I think we're all agreed on the fact that, if you make a conscious choice through having the right information not to have the vaccine, well, that's fine. But what we are now learning, especially from evidence that was published this week from the Siren study in healthcare workers who were having their swabs every fortnight, whether they had infection or not, and looking at whether or not those who had vaccinated had reduced numbers of infection. What the study showed is that 70 to 80% of healthcare workers had 70 to 80% reduced infection rates after the vaccine as well. but also the vaccine reduces your transmissibility. So these were not necessarily individuals who had the obvious infection, but these are individuals who are asymptomatic as well. So by having the vaccination, you're reducing the risk of infection, spreading it to the others. So I would say that if we do want to go and visit our families in other countries, one of the things that you want to be mindful is that you want to spread safety and not increase the risk of spreading the infection to the family. And without the vaccine, you're not only increasing risk to yourself, but you're increasing the risk of transmitting and taking that virus to the family. So why would anybody want to take such a risk in that way as well? So it's worth thinking around. So the safety of people and countries that you visit is going to be improved by having the vaccine beforehand.
Thank you guys for your questions. Professor Johan, I want to come back very quickly because we're fast running out of time on the current research that's happening in our area and how people can take part and what sort of people are we looking for in particular?
Well, there are many avenues people can find out about their research as well. So the NIHR has a good COVID website about research. The Wessex Clinical Research Network also has a website which will point people to where they can get access to the vaccine hubs as well. But also you can get the information in many cases in local primary care practices, but also within hospitals as well. So speak to your doctor about participating in research, and there's always an opportunity, not just because of COVID, but more generally. We want research to be embedded even beyond the virus as well for people to have access to. So there are many avenues, and I'm sure towards the end of the interviews we can give some sort of online URLs where people can access that information, where they'll also be couched in the appropriate language as well, so people can understand the information in the same way.
So when somebody goes in for a research trial, what's the process generally?
Yeah, so it depends. If you're in hospital or in your clinic or in the GP surgery, your doctor might introduce the study to you, ask if you're interested, give you the paperwork, check you can understand it. Normally people have time to look at the information and decide whether they want to take part and ask questions. For the vaccine trials, we are advertising for the different trials because they're each recruiting for a few weeks at a time. And there's either a website or a web address or an email address you can get more information from. And as Anoop was saying, we try and provide that in a variety of languages. So important to tell us what language is needed. But also, when people have read that information, they book an appointment to come and to see whether they want to take part. Booking an appointment for a study doesn't mean you have to take part. You can withdraw at any time. So you can make an appointment thinking you want to take part, go and have a talk with the doctors and nurses and still decide it's just not right for you. So there's no coercion at any stage. By saying you want to find out more, we would love to have the opportunity to give people more information. And as I said before, all of that information's been checked off with an ethics committee who've agreed it and approved it. So different studies take different amounts of time, and all of that is explained in the document we call the patient information leaflet. And that's the key bit of information because it explains in lay language exactly what happens in each individual study.
And my understanding is that in some of the studies, you're compensated for your time?
Well, generally, for things that are considered more complicated or more risky, just by being earlier in the stage of development, then sometimes you are. So we've got some complicated research in Southampton where people are asked to come and spend 2 weeks living in the hospital in a research facility to give them whooping cough to study their immune responses because we're trying to develop a new whooping cough vaccine. Now for that, you get a couple of £1,000 because you're basically giving up 2 weeks of your life to come and spend in the hospital. All of that has to be agreed with the ethics committee. For the early phase vaccine trials, there is sometimes compensation. But actually now we're not doing phase 1 anymore. We're doing the phase 3 trials and the trials of how to work the vaccines out. And there's no compensation for those, but we do pay people's expenses, their parking, if they need taxis to and from. So people won't be out of pocket by taking in the trials. but they won't get extra compensation for taking part in the later phase studies.
If I can sort of wrap up, because I know I'm conscious of the fact that we're running out of time. Where can people go to look up what trials are happening in that area and how we can get involved in those?
So I think rather than us read these out, Ali, we're better off getting Alex and Kim to give you all the different links, and then you can put them on the site or read them out. But I think it'd be quite, because Anoop started to rattle off a list earlier and it was getting too complicated even for me. So we'll find Alex and Kim will be able to collate all that for you and point you in the right direction.
Perfect. On that note, guys, I want to thank you for being on the Community Hour today. We have done this as a three-part series, but hopefully, given time and questions, we may even come back to you for more. But I'm sure in one way or another, we'll be talking to you a lot more. So, and to our guests as well, from the public, we'd like to thank you for coming on to Community Hour today.
The Community Hour on 99.8 Hours FM.
Namaste. Badaine namaskar. Fefshana nisnata tarike. Me ganaine joya che a virus ke kane pidai che. Mane khatri che ke tame ganaine janta haso jene koine chap lage hoy athwa to jate thyo hoy. Apna Bharati ane vanshia samudiyana loko mote bage a chep pachi mrutyu pame che. જો કે તમે તમારી જાતને અને તમારી પરિવારનું રક્ષણ કરી શકો છો. જ્યારે તમને બોલાવે ત્યારે રસી લઈને આ વાયરસથી તે આપની પાસે એકમાત્ર અને અસરકારક સારવાર છે. આ રાશિ સલામત કર્યા કરી છે અને લંબા ગાળા મેં નુકસાનનું કારણ નથી. આ રોગચાળો પસાર કરવા માટે આપણી પાસે એકમાત્ર રસ્તો છે અને એ રસી મૂકીને છે. તેથી કૃપા કરીને અચકાવો નહીં અને તમારી રસી લઈને શ્રેષ્ઠ પ્રયાસ કરો. આભાર.
السلام عليكم. لقاح الكورونا فيروس هو لقاح جيد ومجرب وسليم ويعطي مناعة جيدة تجاه الإصابة بكوفيد، وننصح باستخدامه إذا ما جاءتك الدعوة بزيارة المركز. واللقاح أسترازينيكا ولقاح فايزر الاثنان يعطيان مناعة جيدة تجاه الإصابة بالمرض. فأي لقاح يعرض عليكم الرجاء استخدام هذا اللقاح من أجل حمايتكم وحماية الأشخاص حولكم. وشكرا.